Next, we have Dr. RINU John, and they'll be talking about epidemiological profile and visual outcome of viral keratitis.
So, good afternoon. My topic: clinicoepidemiological profile and visual outcome of viral keratitis in a tertiary care center in Kerala. So, coming to introduction. Viral keratitis, the inflammation of cornea mostly caused by viral etiology, loss of vision secondary to cornea scarring and surface irregularity. When left untreated, they can further cause cornea perforation leading to loss of eye. Herpes simplex virus keratitis is leading cause of monocular infectious blindness in developed countries due to stromal opacification with a higher recurrence rate. Herpes zoster keratitis is the other common cause for viral keratitis and occur due to involvement of trigeminal nerve. Adenovirus subtypes 1, 3, 7 and 14 produces pharyngoconjunctival fever, of which about 13% cases develop corneal lesion which are mild and self-limiting. Cytomegalovirus is the other virus getting prominence in the last 2 decades and is known to affect corneal endothelium. Objective of the study is to describe the clinicoepidemiographic profile and predisposing factors of viral keratitis in patients attending a tertiary care hospital in Kerala, and to study in the visual and clinical outcome of viral keratitis cases. Methods and methods. Source setting was patient with the viral keratitis attending Department of Ophthalmology. Study design: hospital-based prospective cohort study. Study population: all consecutive cases of clinically diagnosed viral keratitis patients attending outpatient Department of Ophthalmology. Sampling technique was consecutive sampling. Inclusion criteria are all patients who are clinically diagnosed with viral keratitis attending outpatient Department of Ophthalmology, and exclusion criteria are patients with mixed microbial keratitis and bedridden patients. So sample size and study tools include self-prepared questionnaire including demography details, systemic comorbidities, predisposing factors, slit-lamp biomicroscope for examining cornea, Sneller's chart for measuring visual acuity, fluorescence strips for staining, 0.5% proparacaine drops. Study procedure: diagnosed cases of viral keratitis was assessed for ocular symptoms, contact lens history, past ocular history, risk factors, systemic disease, and recent or past ocular medications. This is followed by baseline visual acuity examination using Sneller's chart. Both uncorrected and best corrected visual acuity noted. This was followed by a facial examination for any vesicles, facial nerve palsy, and cornea sensation will be checked. Slit-lamp examination was done with a focus on eyelid, conjunctiva, cornea, anterior chamber, and intraocular pressure. Fluorescence staining of the cornea was done to reveal the presence of dendritis, superficial punctate keratitis, and geographic ulcers. Both eyes are examined. Follow-up examination was done on 7th day, 1 month, and 3 months. In each follow-up visit, the patient was examined and the findings are noted, including uncorrected visual acuity and best corrected visual acuity uses Sneller's chart, cornea sensation, cornea opacity, cornea thinning, and recurrent if any. Study analysis by data entered using MSSL and analysis using FP software. All qualitative data and was expressed in proportion, and all quantitative data will be expressed in means, standard deviation, and 95% of confidence interval. The significance of the result was assessed using appropriate statistical tests of significance. So coming to results, the study involved 88 participants, of whom were over 18 years old, and while 21.6% were aged between 7 and 18 years. The gender distribution was relatively balanced, and 56.8% male and 43.2% female participants. So these are the socio-demographic data we analyzed, and the comorbidities included are diabetes, leprosy, and HIV. Other relevant histories are contact lens use, topical steroid use, minor ocular trauma, fever. The signs and symptoms we included are eye pain, redness, watering, discharge, intolerance of light, blurring of vision, irritation, and foreign body sensation. So this is the graphical plotting of signs and symptoms. Other signs and symptoms considered are dead vesicles, eyelid and adenus, and anterior chamber. In anterior segment, cornea epithelial defects included are superficial keratitis, punctate keratitis, discoid keratitis, geographic keratitis, and other conjunctive congestion, pupil reaction, intraocular pressure, lens and cornea sensation. So symptoms we checked in 7 days, 1 month and 3 months with a p-value of 0.01 and signs p-value of less than 0.01. Then the follow-up outcome for study participants were over a 3-month period showed significant improvements in signs, symptoms and signs. Initially 93.2% of participants experienced symptoms at 7 days, but this decreased to 47.7% at 1 month and further to 9.1% by 3 months. Signs of thinning and opacity also reduced substantially. Visual acuity improved over time with the uncorrected visual acuity of 6 and 2 CIS is increasing from 9.1% at 7 days to 45.6% at 3 months, when the best corrected visual acuity for the same range improved from 17.0 to 52.3%. Recurrence rates were low, with only 5.6% experiencing a recurrence of 3 months, including overall positive outcomes and majority of participants. The present study included 88 participants and also we consider this through prior trauma and topical steroid use with the study of Nancy M. Lofty et al. And Kusmesh R. et al. Conclusion: the study demonstrated a significance of clinicoepidemiological profile and visual outcomes in wire keratitis. The result indicates that patients with a more severe form of wire keratitis with cornea thinning and opacification develops worse visual outcomes than the patients who are already diagnosed and treated under regular follow-up.
You are told which viral keratitis you have selected, herpes zoster or something you told, adenovirus?
Adenovirus mostly considered.
No, adenovirus, you are told now pharyngeal fever, that is 3 something you told, 3, 7 or something, that subtypes. What about epidemic keratoconjunctivitis, where you got a subtypes of 8 and 19? You have not mentioned anything about that, because that can produce keratitis rather than your pharyngitis conjunctival fever. Because normally epidemic keratoconjunctivitis caused by 8 and 19, they can produce keratitis. Whereas pharyngoconjunctival fever, they can produce only conjunctivitis and fever. I don't think they can produce keratitis. That means which keratitis you have included? Only zoster.
Adenovirus and zoster are considered, sir.
Okay, because you are not mentioned about the subtypes and all first. Number 2, you have told sensations decreased. Is it decreased or totally absent? Decreased. Herpes zoster, normally we get totally absent. See, decreased means compared to other eye, it is decreased. Whereas absent means totally absent. Zoster, you can now normally expect totally absent. And third thing is what? You have not shown any keratitis picture. Always remember, when you present a patient or something, for a competitive exams and all this, you must present pictures to substantiate. You understood? Because you told fluorescent staining, you told branches and all, herpes, something, dendriticals and all. So you should have shown pictures at least. Okay?
Did you measure the IOP contact or non-contact method? You are mentioned in the anti-segment examination, IOP measured. How do you measure it? Is it contact or non-contact? Okay.
Thank you. Do we have Dr. Sinu Elsa James, Dr. Shirin and Dr. Aisha Sana?